Hello, sir. How are you doing today? Zach, how are you?
Good, man. How you been?
Tired. At about
Mm-hmm.
4. Got up at 7 to. This is now virtual meeting number 4 in a row. Oh, I am Zoom and Microsoft Teams out.
Yeah, no, that doesn't sound too sweet.
You had any traction on your FinBlock stuff?
Yeah, I think a little bit. People have been like submitting IRBs to their various institutions, and so I think we'll be able to put it together. Might take a little while, but
Yeah, all the paperwork side of that stuff is obnoxious. I don't think the actual the chart review side would be very complicated.
yeah. So, I've been kind of just meeting with the various institutions that want to participate and kind of figuring out what they need to do it's a little bit different for each one, but
Mhm.
um, I think it'll come together, hopefully.
Cool.
How's everything down there?
Fine. We finally started taking adult patients on the ped side to kind of offload some because we're boarding up on the adult side, which is entertaining.
Yeah. Are you seeing them, or are they just there?
Yeah, we're seeing them. We kind of, right now, our workflow is that we basically look at our signouts and look at our board, look at the ED board, adult boards, and cherry pick out patients who are younger, simpler complaints and have them come over to us.
Yeah. Yep. Yeah, that's essentially what we do. That's what I always say too. It's like, I don't care what their age is. I care what the complaint is. There are plenty of 22-year-olds with plenty of adult problems I'd rather not deal with.
Yeah.
Yeah, it's kind of funny. Your neck of the woods is like, at least up here, the one part of the country that we haven't heard about like an outbreak, honestly.
Yeah, I feel like our numbers have been surprisingly manageable.
Yeah.
I don't really know why. Because
Like it was like Northeast and
yeah,
everywhere else basically. But
we're certainly it's not politically set up to do well for it.
right. Yeah.
I don't know, warmer, more spaced out. I don't know.
Yeah. Don't kiss a gift horse in the mouth, right?
No, absolutely. I'm not complaining about it.
Yeah. Henry, you there?
Yeah, hey Zach, how you doing?
Good, man. How's everything?
Good, good, good. I was in the middle of the shift, so then I wanted to hop on. Luckily, it's not as I'm not gonna say the B word, but so it's calm. So thanks for presenting.
Yeah, I think I mentioned this. So Carolina, do you know Carolina Vega?
Yep.
Yeah, so we're like gonna co-present. So I was gonna like introduce her to start, and then gonna do it that way.
Okay, that's fine.
You've been good?
Yeah, everything's good so far. So numbers are still kind of low in terms of our seeing patients, which we're not seeing any of the bronchiolitis because masks are actually working. So I actually don't think I've seen a bronchiolitis this whole weekend. I've been on every day. So
I know. Isn't it so weird?
yeah. So
No asthma.
yeah, I'm seeing a little bump in the MISC. I've seen a few kids have been admitted for it already. So so that's interesting to see. But other than that, not much else. The same thing, same old.
Yeah.
Henry, do you mean real MISC or just people with fever with some elevated inflammatory markers without myocardial dysfunction? That's what we're seeing down in
Yeah.
New Haven.
I had 2 last week that were confirmed that, you know, I'll be presenting next week with my fellows. I'll present one case where, like, on my POCUS, there was some like moderate squeeze. So I started pressors right away, but then cardiology came because it came stat because and then they thought it was like borderline low normal. So I was gonna get you guys' opinions on my pictures, but yeah, so I'll present that more on next week.
Wait, but was he on the pressers already?
Yeah. So there's the debate. So I was gonna bring that up next when I present next week, because it's like how fast do they work? Like, you know, versus seeing improvements. But yeah, so but it's been definitely I know I saw 2, and then I know some of my colleagues already seen another one, but be interested to see like the actual numbers, like you say, Lay, because I've seen a bunch that get admitted with just inflammatory labs, but at least 2 of the ones I've seen when I followed up, they've been called MISC.
It might be interesting to survey the group since we have representation from most of the country, or at least on the eastern half, like what our experience. Well, I look forward to the discussion next week, Henry. That sounds very exciting and interesting and relevant.
Yeah, we'll see. So yeah, I'll bring that up. Like I'll probably put a slide in there in terms of like a poll in terms of like how, you know, where we see in. So we'll see. But but it's 1:05, so I'll hopefully that will turn some discussion next week. But this week we're gonna have Zach present. Thank you for that, Zach, and he's gonna be presenting with Carolina Vega, which was one of our residents here actually, who went to Penn Fellowship, and so. But I'll let Zach take over.
Hey guys, nice to see everyone. I missed last week. I've been missing this group. It's been almost a month, so glad to be back. So as Henry kind of alluded to, UMass kind of succeeded in their coup, and we have Carolina Vega joining us this coming summer. And I was chatting with her and wanted to see if she wanted to kind of co-present with me this week, and she was excited to take that opportunity. So as Henry mentioned, Carolina trained at UConn and then has been at Children's Hospital of Michigan for the last 3 years, and will be moving back home to the Northeast soon. So she's going to take the first half of our presentation this week.
Thank you, Zach. I appreciate it. Thank you for the opportunity to present a few cases this afternoon. So I'm going to share my screen successfully, I hope. There we go. Can everyone see the PowerPoint?
Looks good.
Fantastic. I'll put it in presenter mode. And so I have 4 cases to present this afternoon. Case 1, we have a 5-year-old male with right-sided jaw and face swelling for the past day. He has associated pain to the right mandibular teeth. No fevers, however, and is partially vaccinated. I was consulted for this case by a colleague, and I think I missed a screen. Oh, here we go. And found that the patient had erythema, induration, and tenderness from the right inferior cheek extending to the submandibular area. He also had associated lymphadenopathy in the anterior cervical chain and also the submandibular, and tender right mandibular premolars. And so I did a POCUS scan for him prior to his radiology imaging and started with the right cheek. And so you can see here that we're starting to form edema throughout the superficial layers, and the subcutaneous, we're starting to form some cobblestoning. There was a hypoechoic area here, which I wanted to investigate further. So I put some color flow on it. So you can see certainly vascularized, not any drainable collection. And then I moved to the right submandibular. And you can see here, we do have this large what looks like an anechoic fluid collection, but there's this hyperechoic stalk extending into it. And we're able to confirm our suspicion of what it is by putting color flow. So you can see this is a very classic example of reactive lymphadenopathy or lymphadenitis. We have hyperemia extending into the stalk, surrounding our lymph node. And so certainly we should not attempt to drain this. And here's another example of one of his reactive lymph nodes. Again, you can see that enlarged mushroom shape with the hyperechoic stalk, and a nice example of the hyperemia extending into the stalk and around our lymph node. And so based on my POCUS exam and scanning was consistent with lymphadenitis and cellulitis, no signs of abscess, and that was confirmed by our radiology scan. The patient was admitted on IV clindamycin, and his S and T teeth were extracted, which were his likely culprits. Does anyone have any questions on this one? Okay, I'll move to case 2. We have a 16-year-old male presenting with left lower quadrant pain and bloody stools. He had onset of bloody stools 6 months prior and is awaiting colonoscopy. He does have associated tactile fevers, headaches, and weight loss, and came today for abdominal pain and bright red blood per rectum. On exam, he is tachycardic, ranging 140 to 190, but irregular and having occasional drops to 90. This in the setting of having intact peripheral pulses and appropriate mental status, and is unsurprisingly guaiac positive. I was consulted for this case after a shift by a colleague, and they told me about this EKG that they had just obtained, which you can see these regular PVCs consistent with ventricular bigeminy. And so I did a POCUS scan when we were waiting for our cardiology clinic colleagues, and starting with parasternal long. What's interesting is that you can appreciate ventricular ectopy here, transmitted through all the cardiac muscle and especially visible in the valves on all of my 3-second clips. I included a 1.5-second clip to emphasize that if you cut the clips with this sort of presentation, you won't have the opportunity to capture it. And so we can't see it in this one. Function for him was grossly normal. We can tell his EF is likely more than 55 despite this. I did do EPSS for him using M-mode, throwing the pick through the distal end of the mitral valve. We can see his EPSS is appropriate, measuring from the E wave to the septum, 5.1, less than 7, perfect. And I continued to progress through all of his scans. Mitral valve, we can see similarly the ectopy being transmitted through right here. And this is actually my favorite one, since you can really appreciate it going through the aortic, pulmonic, and tricuspid valves. No effusion, of course. And apical 4 the same, right there in the middle. And I included IVC to demonstrate that we have no signs of plethora, no signs of overcollapsibility. This looks appropriate other than the ectopy that we can appreciate throughout, and a partial aortic view with the same. And so this patient was admitted for observation. Cardiology team recommended outpatient Holter and clinic follow-up, and he was discharged pending his scope for IVD. The echo in clinic confirmed what I had found, which was frequent ventricular ectopy and otherwise normal. So that was nice to see that it matched up with our bedside examination. Are there any comments I'm missing? I'm not sure if I can see it when I'm in this mode. If anyone has any questions, but I will go to case 3. We have a 3-year-old male with forehead hematoma after a fall into gravel. The parent is worried that in trying to remove a pebble from the wound, they may have actually pushed it deeper inside. This patient had a large quarter-sized hematoma on the left forehead, which is swollen, tender, and does have a small abrasion in the center that's now closed, and there's no visible foreign body. And so one of our fast track providers consulted me for this scan. And so I started in the x-axis for him. You can see here, this is a suggestion of a posterior acoustic shadow, potentially a linear marking. And so I scanned again, and then we confirm it. Yes, we see a small linear marking here with a reproduced posterior acoustic shadow, implying a solid object. And so I got scans from the y-axis as well, so it is important to get perpendicular scans. And we can see here, we're slightly wider in the y-axis than we were in the x. And at this point, the child was a little bit less cooperative with the exam, so there's a lot of motion artifact, but we can appreciate that, yes, we do have a small foreign body in the wound. I put color flow on it to confirm that we have no complicating factors, and then was able to measure it. The depth at the maximum was 1.1 millimeters, likely a little bit less since I did measure to the start of the posterior acoustic shadow, but our linear marking is in fact right here. The width of it is 1.7 millimeters on the x-axis. The patient at this point was inconsolable, so I was unable to strictly measure the y, but from our clips, we can appreciate that it was approximately 2 millimeters by 1.7. Ultimately, a small pebble was able to be extruded and removed, and the patient was covered with prophylaxis with Keflex. So I thought that was a nice example of the applicability of POCUS, since you won't be able to always visualize our foreign body. Case 4. We have a 6-year-old female with dysuria, fevers, and left flank pain. Her symptoms are associated with emesis, and she was started with PO and amoxicillin yesterday for UTI with PCP and vomited the second of 2 doses. Is found to be febrile here to 38.4 and does have mild suprapubic and left lower quadrant tenderness. She does not have any CVA tenderness or peritoneal signs, and her urinalysis is grossly positive and suggestive of UTI. I assumed care of this patient at change of shift, and to help with disposition, I did do a POCUS scan. And I started on the right kidney. If you remember, she had pain on the left flank. And so what's interesting is even though this was the non-tender side, you can see that she has mild calyceal dilation right here as I fan all the way through. Mild hydronephrosis, so she does have pyelo on the right kidney. Looking at the short axis, we can appreciate the same. We've got this mild calyceal dilation here in the center, ureter going in. Moving to the, I fanned a little bit less with this clip since I wanted to emphasize to myself and my colleagues this calyceal dilation we were appreciating. And then I moved to the bladder. What was interesting for this one is she did have very characteristic circumferential bladder thickening that goes along with cystitis, which I don't always appreciate for the pyelo cases. Sometimes I'll just see the hydro in the kidney. No debris, but that's not obligatory when we're examining, when we're visualizing cystitis. Sagittal view, we see the same. If you place color flow, you should be able to appreciate hyperemia and thickened wall as well, which further supports your findings. Left kidney, which is where she had had the pain in the left flank, is entirely normal. We have this ureter going in, normal pelvis, normal calyces, perfect left kidney. And so her diagnosis was right pyelo and cystitis by POCUS exam. This was ultimately confirmed with the radiology ultrasound, though there was a time gap of 4 hours to obtain that. So during that interim, we placed the IV, started ceftriaxone for failed outpatient treatment, requested the bed, labs came back, CRP was 63.5, white count was 12. She did have significant neutrophilia, developed Rigers, had a bolus given, had symptoms improve. And when the ultrasound was done from radiology, she was able to go straight up. So it was nice that we were able to facilitate care and determine disposition during that otherwise prolonged time gap. And these are the references I used in preparation for this presentation. Does anyone have any questions?
What exactly did radiology see on their ultrasound?
The same. They found right pyelo that was right mild hydronephrosis and circumferential thinking of the bladder that suggested cystitis.
But what was
this is Lay from New Haven, Connecticut. Sorry.
Yeah. Go for Lay.
My question is, what's the pathological correlate of that mild kaliectasis or whatever you call it? Because we don't always scan uncomplicated UTIs. I know she became a failed outpatient, but I was just trying to understand the ramifications of those findings. She was not symptomatic on that side, yet there was a POCUS abnormality. Again, I open up to the group. What's the clinical correlate of this POCUS finding?
From my standpoint, we felt that with the new vomiting, that she did merit inpatient treatment, but I welcome anyone else to comment as well.
So, hey, Lei, I'm used to looking for like nephrograms. So, some sort of like wedge artifact that's representative of pyelo on ultrasound.
Yeah, I usually think of my uncomplicated as probably being nothing, if not like I've had some that was more like pyelonephrosis, where you could actually see, hyperechoic or relatively hyperechoic pus, or like thickening and almost like sloughing of some of that pelvic lining, where it almost looks like it's like tram track sort of thing. I don't know if I would say this is, I would wonder if when healthy, if she doesn't look the same way.
I think they plan to do a follow-up ultrasound. I just haven't had the opportunity to see it yet. I thought it was just worthwhile including, since we typically have the opportunity to see the moderate and the severe, and not as much of the mild hydros. Are there any additional questions before Zach takes over? Thank you.
Thanks, Carolina.
So while I get set up here, are you guys seeing my slides? Sorry.
Yep. Yes. Bob.
Okay. So I'm not going to be as nice to you guys as Carolina was, and I'm going to insist on some more group participation, mainly for my own benefit, of course. So here we go. Going to present a few cases to the group. So the first case is a 16-year-old female presenting with 3 weeks of abdominal pain. She was previously healthy, and she was coming in with 3 weeks of kind of diffuse crampy abdominal pain, which had been intermittently sharp. She described feeling very gassy with a decreased appetite. She thinks she had appreciated some weight gain, some lower back pain. And then, of note, she was saying that she was frequently being woken up by this pain. She had had pretty persistent nausea and vomited at a single time. On her exam, she had a soft, diffusely distended abdomen, just really prominent throughout kind of the lower abdomen. It was diffusely tender without rebound or guarding, and she had no appreciable HSM. And before I go to the images, the best way I can describe what this patient looked like was she looked like she was either 16 weeks pregnant or someone with liver failure with chronic ascites. She just had this big kind of protuberant lower abdomen. Okay, so started with some fast views. You have a right upper quadrant view on the left and a pelvic view on the right. And hopefully you can appreciate fluid in Morrison's pouch and also free fluid in the pelvis. Early in this image, you kind of appreciate that the bowel is just being kind of surrounded by free fluid. So focusing in on the pelvis a bit more. So we have 3 images here. So in the top left, what you're actually seeing is her free fluid, or her ascites, is literally outlining the pelvic structures. So you have her right over here, her uterus here, her left over here, and a bunch of free fluid. This is just another angle on the upper right. And then the lower image is just kind of a zoomed in view. I then turned 90 degrees into a more sagittal plane. Oops, sorry. And hopefully you're appreciating something abnormal. So again, a lot of free fluid behind the bladder. You're seeing the left ovary kind of outlined in fluid. And I put color on it, and didn't see any particular internal flow. So I would open it up to the group at this point. With that presentation and these images, what are people's like initial reactions or thoughts or concerns for this patient?
I wonder that being like some sort of ovarian tumor, like a teratoma, given sort of the mixed, like the well-demarcated mixed echogenicity of what you're seeing there. Although no color flow.
Yeah, I mean, I don't know about everyone else. I feel like I see ovarian, hemorrhagic cysts, or various kinds of cysts all the time. To see profound ascites was not typical for me, and so pretty much kind of everyone involved in the case was very concerned that this was malignant, given kind of the general appearance of the ovary, but then also her kind of profound clinical presentation. And then I included this. I thought this was pretty interesting or cool, or depending on your perspective. But so this is the POCUS on the left, and this is like the best CT cut on the right. And the point I was just hoping to make here is, I don't know about anyone else's opinion, but I feel like you get a lot more detail and internal kind of characterization of what's going on from the ultrasound compared to the CT. I just thought that kind of the juxtaposition was pretty profound. So I wanted to include it. So this girl was taken to the OR. They aspirated the cyst and sampled the free fluid. And luckily enough, neither of those showed malignancy. She had tumor markers drawn, which initially was showing an elevated CA-125, which is subsequently downtrended. And she currently just carries the diagnosis of a large luteal cyst. So I don't know. I thought, both the presentation and these images were pretty cool. I don't know if anyone has any thoughts or comments, regarding this case, or looking at ovarian pathology with our POCUS.
Zach, was that blood in the peritoneum?
Yeah, so it wasn't, and that was kind of a cool teaching point for the residents. Let me see if I can find a good image. But with 3 weeks, and feel free to agree or disagree. If this had been blood, I would have expected it to start to show kind of that layering out and kind of coagulation, which we really weren't seeing, which I thought was kind of interesting. I don't know, do you agree, Lay? I never got the impression that it looked like blood that had been sitting there for 3 weeks, but
Oh, I'm just asking for information. I think this was a very interesting and unusual presentation of what sounds like a common problem. I'm just surprised at the amount of free fluid, and just was wondering the characteristics of it. I mean, we see a lot of hemorrhagic cysts, and with sort of trace free fluid, it turned out to be blood, or at least
Right.
we presume it's blood. But yeah, since you have almost a liter of fluid in it, I was wondering what the characteristic was.
yeah, no, I was shocked too. it still doesn't exactly make sense to me, I'll be honest. You know, I'm glad for the patient's sake, but you know, how a luteal cyst led to that profound of presentation, you know, I still don't know that I've can, you know, entirely wrap my head around that. But you know, it's a good thing for her, I suppose. Okay, so moving on. So this was a case, it was a 2-year-old transferred from an outside hospital with intussusception found on ultrasound. So 1 week of abdominal pain, constipation, vomiting, was having pain with bowel movements. And then the mother had noticed that, you know, his gait seemed to be a bit off today, and she thought he was kind of favoring his right side. Initially, he was at an outside hospital where he got a radiology ultrasound, which showed an intussusception. And I guess, you know, just weren't comfortable with managing a 2-year-old, and that's why they were transferring them to us. So my regret with this case is that I don't have any clips. It's all stills, but I think stills is kind of a cool case. So, you know, Adam's on the call and he'll be kind of ashamed to hear this, but, you know, typically when I'm doing my, you know, abdominal or API scans, you know, I kind of use typically like the landmark approach, the psoas, and the look for the iliacs, etc. So this is the right lower quadrant. And even in the still clip, I think you can appreciate that you're getting, you know, outlining of the bowel consistent with free fluid in the right lower quadrant. And I'll just note that, you know, we didn't really appreciate much beyond kind of what you're seeing here, you know, kind of some nondescript bowel and some free fluid. And then marching up, it's a little hard to orient, but if you look screen left of all these images, you're seeing the gallbladder. So if that helps to orient, you know, we're kind of in the right upper quadrant. And we, you know, come upon this structure. So there's these images and then these images as well. And I'd open it up to the group, maybe, you know, anyone really, but if, you know, if there were a trainee or someone wanted to kind of venture a guess as to what we're seeing, you know, do we agree with the diagnosis? What about this is consistent with an intussusception? What isn't? Anyone have any thoughts?
And the location is right, but the images, I'm not seeing like the multiple layers that I'm accustomed to. So I'm not seeing the classical target sign. It is in the right place in the right upper quadrant, and most of them are, but I'm not seeing the class like target sign.
Beautiful. Yeah. I mean, I think that's well articulated, right? And I mean, obviously, if you're catching an intussusception, depending on the angle, it can have various appearances, but I kind of think this one on the upper left was kind of the most elucidating to me, because you're seeing, you know, internal characterization of this structure, and I'm not seeing, you know, any layering or, you know, something suggestive of intussusception. So, anyone want to venture a guess at the ultimate diagnosis?
So my guess would be with a week of symptoms in a toddler, and there almost looks like there's some posterior acoustic enhancement to that lesion. So I'd be clinically worried about a perforated appendix, common things being common.
Beautiful. Right. So I think this kind of represents, like, you know, in one way, common things being common, but then, you know, given the location, and I mean, you could sort of picture how with that, like, well kind of circulated shape, you know, they may have been, you know, giving them credit, may have been kind of thrown off line or off target. But yeah, very good. Perfect. So perforated appendicitis, you know, I'm imagining he had kind of a one of those appendixes that kind of bends up towards the liver, perforated, managed to wall itself off, and we're kind of catching it at that point. Excellent. All right, so this next one, will also end up opening it up to the group. So this was a cool case. So 16-year-old female with bilateral embedded earrings. So this girl had large hoop earrings in, and for whatever reason, they'd been bothering her. So she had put the starter earrings back in, which I've come to learn are like those very little kind of just circular stud looking earrings. And now she's coming in with pain, redness, swelling, and actually some now resolved, but had some purulent discharge right more than left. And she comes in because she can't get the earrings out. So I open it up to the group. So this is the girl. So on the left is her right ear. On the right, screen right, is her left ear, just to be confusing. So you have this girl come in. What's your plan? What are you going to do? How do you think about managing this patient?
I think we should ultrasound it.
I agree, Julie. I agree.
So what are you looking for, Julie?
I'm looking for a retained foreign body and for abscess.
Yeah, honestly, I didn't even ultrasound her earlobe, to be honest with you. She was old enough, to know that the earring was in there. I guess in hindsight, it would have been interesting to see what it looked like, but I didn't actually even put the ultrasound probe on her earlobe. Julie, what would you do with this girl? Like, let's say you saw, earrings, foreign bodies in there and some surrounding like early abscess formation or pus or.
No, it needs to be opened up. The foreign body needs to be removed.
Agree.
She needs to get antibiotics.
How are you going to get it out? Like, logistically, what are you going to do?
I guess it depends on where I see it. So like I think if it's really superficial, that's one thing. If it's deeply embedded, I'm not going to go slicing open her earlobe. I might involve ENT or plastics for that. I probably start also with some LMX and see if it spontaneously opens and drains, because that's always helpful. Then you can sort of pop it out. But if not, if it's complex, and also, how long did you say that this has been going on for?
She was kind of like a squirrely teenager, so it was a little hard to say.
Because the longer it's going on for, I get suspicious
Yeah.
for scar tissue, and I don't want to be messing. I don't want to mess up her earlobe permanently.
Yeah, no, I think those are all good points. Anyone else want to jump in?
I mean, the only difference, I guess it's like how you manage the pain control.
Yep.
I would do an auricular block. I like those. I mean, they work really well, especially when I had foreign bodies that are stuck there and I need to make an incision.
Henry, can you when you say auricular block, and maybe put your video on, what exactly do you mean? I'm curious.
Give me a second. Let me do that. Give me a second.
No, it is not your fault.
You're muted, Henry.
Sorry. So I basically go in the inferior pole of the earlobe and sort of go in the B shape, the classic that they show us in there. If it's located just in the lower, I just do the bottom half. I don't actually do the top.
Yep.
I only had an issue when it's like right in the middle about numbing both places, but I'd had successful when I had a foreign body that's stuck in there that wouldn't get out, just numbing it and making an incision, and they work well. And I find that patients tolerate it really well. So that's the way I control the pain management.
Great. Okay. And it sounds like you've had good success with that block.
Yeah.
Okay. So, one alternative, which I wanted to talk about kind of as a group, let's see if I can do this, is the superficial cervical plexus block. So this is actually what we ultimately did for this young lady. So you can see, so this nerve bundle, it's a superficial nerve bundle, and it kind of comes out and emanates from behind the SCM. So I don't think I have my pointer, but you can see there that all the nerve roots are kind of originating just posterior to the SCM. And this nerve bundle innervates not only kind of the lower aspect of the ear, but also the lateral neck, and extends all the way down to over the ipsilateral clavicle. And so can be a very effective block in a number of contexts. So, one is for like lower lobe earlobe issues. The second one is it's been shown to be helpful in pain control of clavicle fractures. And then the final one, which is in putting in an IJ central line. I've seen it argued that, the standard of care should be to start the procedure by performing this block, which literally numbs all the relevant areas to the point where all your like future manipulations, insertion of the needle, securing the line, you've anesthetized all those areas really effectively with one block. So just briefly, kind of the anatomy and how the block is performed. So on the left, one is the sternal notch, two is the thyroid cartilage. That kind of dashed line is the SCM, and the star is where this like nerve bundle kind of emanates. And we're all kind of familiar with some of the tactics for procedural focus, but having an assistant and having the machine on the other side, et cetera. And then these are the images you get. And oh, are you guys seeing the arrow? Maybe.
Yes, I am.
Yes. So these are all the same patient, kind of taken at different levels. So sub-Q, SCM, and unlike, let's say, like our femoral nerve or some other nerves, the nerve bundle here isn't like as much of a discrete triangle. It's this whole kind of diffuse patch here, which hopefully you can kind of picture that, it has kind of the characteristic of a nerve, just a little bit more like spread out. You're seeing it here as well. And then this just demonstrates, this is with the patient's like neck turned to the contralateral side a little bit. So in general, again, pretty safe and easy in the sense that, the relevant vasculature is here. As always, I'm proving to myself that I know where that is, and that it's nowhere near where I'm going. But the technique is all you have to do is get under the fascial plane that makes up the lower aspect of the SCM. And if you inject there, the anesthetic will actually spread for you and get all the relevant structures. So it's a plain block, and you can literally insert your needle very, very distal and, be kind of very far from the vasculature. We did this actually bilaterally on this girl. The right side definitely needed some good pain control. The left side, maybe you could argue we were doing it more for practice, not to be, not that we like to practice on our patients, but, and it was incredible. The block was like really, really successful. She, was totally able to tolerate us like manipulating her ear. We didn't actually even need a scalpel. We kind of just at that point used like more blunt force and kind of pushed the earring out through the granulation tissue. And then just to kind of like prove it to ourselves, we did kind of like poking around, and she was completely amnestic, like all the way to her sternum, over her upper chest, over her neck. You know, it was really pretty cool. The one thing I kind of learned in hindsight, which you know, I would take with me the next time I attempt this block, is the hardest part is kind of accessing the area. So you kind of get the sense of that from this picture, but you have to have your probe over the lateral neck and the approach is posterior. So what we ended up doing with our patient was we had her actually just sitting up, like at 90 degrees, which gave us access, but it wasn't like the sturdiest positioning ever. And then I was doing some kind of looking and reading afterwards, and basically what they suggest is just putting the patient in like lateral decubitus position and just having them lay on their hip. And it really kind of just opens up the entire area for you. So, you know, just trying to kind of incorporate these blocks whenever possible. You know, I would put this in the category of pretty easy and pretty safe, even though it is the neck. And, you know, I'm hoping to kind of incorporate these more and more. I don't know if anyone, you know, has any experience with this block or thoughts regarding this block, or would never have done this block and think I'm stupid for sticking a needle in this patient's neck, or any thoughts?
No, Zach, I had a couple of questions. So one is, what indications for the block? So you said the clavicle and the ear. Is there any others? And two, like, what are the things that can go bad? Like if I were to mess this up.
Yeah, I mean, so, you know, the indications are kind of anything from the lower aspect of the ear through the clavicle. So the classic examples they talk about are, you know, pathology to the lower ear, either like a bad laceration or a retained foreign body, clavicle fracture. And then, you know, they talk a lot about like pre-treatment for like IJs, right? Because, you know, you're inserting your needle here, but then at the end of the procedure, you kind of have to suture the line right here. So this one block kind of takes care of all of that. You know, I suppose if you had a gnarly laceration like over the upper chest, you know, it would be effective, but those were kind of the three main ones I saw. You know, similar to any block, you know, I would say the number one risk is, you know, injecting into a vascular structure. And then, you know, it carries the same risks as any other time you put a needle into someone, you know, infection, et cetera, et cetera. You know, the way that I try to mitigate that is even blocks I've done a number of times. Before I do it, I look at, you know, the Highland Ultrasound website, just remind myself all the relevant anatomy. They have a list of pitfalls there. I always make sure I know where the nearest, you know, vascular bundle is and prove it to myself with color. And, you know, that's kind of it, you know, other than the fact that it's the neck, which kind of carries with it, you know, some natural apprehensions. You know, this is, you know, you're literally inserting the needle only 1 centimeter through a muscle, you know, so, you know, you could argue kind of minimal risk in that sense. Okay. I will move on. So again, this one maybe will be like a good lead into Henry's discussion next week, and Lay and everyone else who was seeing more of this COVID related stuff in the spring. You know, I'd welcome your guidance on this one. So 17-year-old female came in not feeling well. She was complaining of a headache, 3 days of fever with a Tmax of 103, myalgia, sore throat. She had been confirmed COVID positive 5 months prior, you know, which was a bit outside the typical window, but, you know, with the 3 days of high fever, we have this kind of like initial screening panel for these MISC kids. And you can see the labs there. You know, the CRP was significantly elevated. The white count wasn't crazy. There was a trope bump, but not, you know, the biggest I've ever seen. and then the question is, might this patient have MISC? So I want to show, so this is her echo. I'll preface this by saying that she wasn't the most compliant patient, and I guess I'm somewhat satisfied with these images, but it was a little bit hard to echo her, was my recollection. So parasternal long, parasternal short, subxiphoid, and then unfortunately this on the lower right was the best apical 4 I could get. And so I guess I would welcome like your guys' opinion as to your interpretation, particularly of these images I have on the screen here. And then afterwards, I'll tell you why I'm asking. And I recognize they're a little choppy for some reason, but. Does that make it better? Yeah. It's not like meant to be a trick question. I just want to see if, I guess, people agreed with my interpretation.
Looks like there's little pericardial effusion in one of the images in the upper left, I think.
Yeah, so that's what I called. Here and here. I didn't. I don't know. With these 4 images combined, other people on the call, would you call a trace pericardial effusion? I kept going kind of back and forth on this question.
I was always taught that if you have to squint at it, then it's probably not the cause of your symptoms.
Right, which I 1000% agree with. The problem was I wasn't trying to attribute this to her symptoms. I was trying to use it to risk stratify her, which may or may not have been appropriate, but I guess I'll speak to that more in a second, but I completely agree with that sentiment, Julie, 100%.
And I also couldn't appreciate it in the parasternal long one. I think I would call it probably non-clinical significant effusion or trivial effusion, because I don't really appreciate it on the parasternal long.
I think Chris Moore would call this no significant pericardial effusion.
Right. So that's funny, Julie. So literally the comprehensive echo, and I quote, no significant pericardial effusion. So very good. So I guess my question for the group. So we had this girl story, at least to my understanding, not like perfectly consistent, given that it had been closer to 5 months, somewhat elevated inflammatory markers, but not like blowing you out of the water. And then you find this. I guess, does this change? I mean, my ultimate decision was where this girl needed to go. In our facility, if the patient needs monitored tele, they go to the ICU. And so I was trying to decide, I guess, if this would contribute to my decision as to where to put her. And I'd be curious, just anyone else on the call's like reflection on that kind of decision point.
Zach, I was just telling our residents that, COVID has made us all stupid. I mean, I used to know what to do with a non-exertional chest pain, borderline tachycardia, but now I have to worry about all these other things like a pulmonary embolus that we didn't worry about exactly a year ago. So I think it really comes down to, how ignorant we are about the pathophysiology of this new virus or whatever we are attributing to this new virus. So I don't think there's a clear answer of what would be the right thing to do, because we're all risk averse. but to what extent are we risk averse? Are we subjecting these children to many, many tests that in the end do not necessarily benefit them, but covers our own rear end? And I think that's a dilemma that we're all struggling with in the era of COVID.
No, yeah. I mean, it kind of sucks. Working in this environment, I feel the exact same way. I feel like, your knowledge and your experience are just kind of like put on the back burner, and you almost, I don't know, it's not, it's frustrating. I agree, exactly with what you're saying. Um, and I guess the final thought that, was brought up by a PICU attending, and I don't know the answer to this, but does having, this trait, so, the reason you would put someone in the ICU and put them on tele, is the risk of ventricular dysrhythmia, right? That's like ultimately the thing that will cause a major problem. And does this finding, make the person more likely to develop a ventricular dysrhythmia, overnight? I don't know the answer. I don't know, but I thought it was kind of an interesting point that was posed. I don't know. I guess, do all of your thought to be possible MISCs is kind of the routine at this point? Do they go to a specific place? Do they get their echo before? Like, what's kind of the flow been for your shop?
I defer to my other colleagues. I sort of don't know what the right thing to do is. I mean, I don't think there's a clear policy. Like many other institutions, we have these screening labs which are overtly sensitive but non-specific. So a lot of children are in with inflammatory markers. And if they look well, they do not have, we often do a POCUS. If they have no signs of myocardial dysfunction, they don't get an acute echo, but they do get admitted. I've had most of them go to the floor. Again, that's just institution specific. There is tele ability on some of the inpatient pediatric floors. So yeah, I haven't had a very sick one over the last month or two. We've had back in the summer, end up by ECMO, et cetera. But the ones we've had last few weeks are mostly just, laboratory diagnosis of MISC rather than the clinical, myocardial dysfunction, shock, respiratory failure, kind of the kids that we were worried about back in the summer.
Yeah. And I've even heard people muse, is it just that we're sending labs on all these kids, or are people more hyper acute to what's going on? I've had the same experience. Almost everyone comes in with this high fever, but not terrible looking, not terrible vitals, and some elevated inflammatory markers. It's just kind of and then, it's this big what to do. Anyone from LIJ on the call, or, I'd be curious, or Adam, or, anyone closer to New York City, or.
Here at Cohen's, we've been doing similar as well in terms of, sorry, give me 1 second. In terms of admitting if the markers are elevated and they're showing some tachycardia, we've been admitting to the floor. If they're showing elevated markers, but they're otherwise well appearing, ID has been following them outpatient as well. Just recently, we did have, if there's any signs of cardiac dysfunction on POCUS or echo, they've been going to the PICU for monitoring, or if needing pressors, of course.
If you had seen this, where would you have disposed this young lady? Just as a thought experiment.
Yeah, likely this patient will probably go to the floor here. She was otherwise, well, she wasn't ill appearing from the beginning of the story, right?
Yeah, no, not particularly.
Yeah, this patient would likely go to the floor.
Yeah, floor with tele probably.
Is this the rest of our careers, or at some point we're going to feel like we know what we're supposed to do with this?
I've done more CT angiogram looking for PE the last few months that I've had in the past 15 years combined, I think. So yes, I'm afraid.
Yeah, and Zach, this is Matt down in South Carolina. I agree. We sending labs on kids I never used to send labs on, and then wondering, I was like, oh, the D dimer's elevated. I'm like, I have no idea what to do with that. And I feel like early on, in a very sort of reactionary sense, we were doing lots of labs, and I have more recently stepped back, sort of going back to kind of like some of my like residency folks who would talk about like Kawasaki's and how like, you know, it's a vasculitis and sort of a, therefore like a hurting, uncomfortable thing. And for the kids who have the history, but like look well and, you know, don't look uncomfortable, I've been doing less and less and feeling more comfortable with the less and less. I'm not aware of that having, you know, been somebody who came back and gave me the EPEC alert in 72 hours, your patient came back and looked floridly ill. But I don't, information without, you know, knowing what to do with it, I still don't know.
Yeah. Well, not to end on kind of a negative Nancy note, but I had one more, but I'll probably stop there. Again, it was really nice seeing and chatting with everyone. Yeah, hope everyone's doing well.
Thanks, Zach, for presenting. And I think I'll try that vlog at some point. I just got to feel cavalier that day. But thanks a lot for presenting. So,
of course,
our adult guys do that one a fair bit for some of the same stuff you mentioned. We've done it. I can't remember which things I've had done on me and done to other parts of our group in our conferences. I don't know if we should be doing that or not, but on either side of that, it's not uncomfortable or hard to do.
Yeah.
But we can travel again. If you want to come to be a model on our conferences, please.
All right, guys. Thanks again.
Exactly.
Nice job, Zach. Have a good day, guys.
Thanks, man. You too.